Hi, Dr. Bhargava here. This is the next video in the series Body Imaging Case Review. This is our first patient. They presented with a mass in the pelvis, and this mass is complex cystic, and it's a female patient. We can see on the sagittal image the uterus and the urinary bladder. It may seem like there is an air fluid level, excuse me, but there is layering fat in this mass. And so this mass is a fat-containing tumor arising in the female pelvis. That would be a benign cystic teratoma or a dermoid cyst. Always look for macroscopic fat, and it could be layering like this. And when you see fat in a pelvic tumor, it is most likely to be a mature cystic teratoma or a dermoid cyst. Here is our next patient. They presented with abdominal pain, a young female, and we performed a CT of the abdomen and pelvis. In the pelvis, we see this corpus luteal cyst in the right ovary, and that has ruptured because we see some fluid around it. It's a common cause of abdominal pain in young females, the corpus luteal cyst rupture. Sometimes we are able to see a discontinuity in the wall of the corpus luteum. Sometimes there is hemoperitoneum, which could be life-threatening. This is our next patient, and they were suspected of having a pheochromocytoma based on their symptoms and blood tests. So we performed a CT of the abdomen and pelvis. There is this large heterogeneous enhancing mass arising from the left adrenal, also seen right here on the coronal and right here on the sagittal. And so this patient underwent a DORA-8 PET-CT to confirm the diagnosis of a pheochromocytoma or a neuroendocrine tumor, and also to look for metastatic disease. So here's a rotating image. We see physiologic uptake in the pituitary, salivary glands, liver, spleen, excretion from the kidneys into the urinary bladder, and we see this intense uptake in the mass that is arising from the left adrenal, seen here and here, consistent with the pheochromocytoma. And this patient can undergo a curative resection because there is no evidence of metastatic disease on this DORA-8 PET-CT. This is our next patient. They presented with nausea, vomiting, and abdominal pain, and obstruction was suspected. We performed a CT of the abdomen and pelvis. We find that the stomach is distended, small bowel loops are distended, and they have a hiatal hernia, a inguinal hernia, which we see here, which is the site of bowel obstruction, also seen here. We see a bowel loop going into the inguinal canal, and then it comes back. Distally, the bowel loop was collapsed. Proximally, the bowel loops are dilated. And so the axial image is not very clear because of the streak artifacts from the left hip prosthesis. This patient was diagnosed with bowel obstruction secondary to a left-sided inguinal hernia and underwent surgery. This is our next patient who presented with a scrotal mass, and an ultrasound was performed. So on this top left image, we see that there are no testicular masses. This is the right testicle, here is the left testicle, the blood flow is symmetric. And on this top right image, long axis view, inferior to the right testicle, there is this large heterogeneous mass which is hyperemic. And generally, the extratesticular intrascrotal masses are benign, and intrascrotal intratesticular masses are generally malignant. This case turned out to be an exception to this rule, and the surgery showed that this was a paratesticular Ewing sarcoma, generally a primary bone tumor that was a soft tissue mass right next to the right testicle in this patient. Here is our next patient, and on this chest x-ray we find this bullet fragment, and this is projecting over the right lower lung field. We cannot tell on the single image whether it's anterior or posterior or in the chest wall or in the lungs. So on the CT scan, we find that this is in the chest wall, posteriorly seen right there, and here's the coronal image showing that it is in the soft tissues of the right chest wall. Here's our next patient. We performed a CT abdomen and pelvis with contrast to look for a cause of abdominal pain, and the patient moved during the acquisition, because of which we see this step ladder appearance involving the superior pole of the left kidney. And also on the sagittal image, we find that the images are limited in the upper abdomen right there with these artifacts. So this is characteristic motion artifact on CT. best visualized on reconstructed images, not as much on the axial image, because on the axial, as you are scrolling through, there will be some jump from one to the next image, but the artifact is seen on the reconstructed coronal and sagittal images. This is our next patient. Here we performed a CT after administering contrast through the rectum. So we see the contrast in the rectum on this axial image. We see some contrast in the ascending colon. We see that the colon itself is thickened. There is some surrounding fat stranding. There are diverticuli also seen here. And there is a communication between the colon and the vagina, seen right here, a subtle finding, and also the urinary bladder, because there is non-dependent air. So whenever there is non-dependent air in the urinary bladder, think of communication with the bowel loop or infection from a gas-producing organism leading to cystitis. So this patient had diverticulitis, and as a result of the diverticulitis, they developed a colovesical and colovaginal fistula. The uterus is absent from a prior hysterectomy. Here is our next patient, a young female presenting with abdominal pain, prior history of C-section, and abutting the anterior wall of the urinary bladder and the abdominal wall, there is a ill-defined mass that shows enhancement, also seen here and here, consistent with a C-section scar endometriosis. This is our next patient. The finding is incidental. We performed a CT abdomen and pelvis to look for a cause of abdominal pain, and we incidentally found skin thickening involving the inguinal regions bilaterally, also seen here and in the midline extending into the perineum. There are these verrucous growths, and these are from condyloma acuminata. There are some regional reactive lymph nodes as well. This is our next patient, and here we have performed a CT abdomen and pelvis, and we see this artifact. I'm going to draw a line adjacent to this ring artifact, and so ring artifact is frequently seen on CT images when the patients are large or pretty close to the gantry, or when one of the detectors is not working. So it's a ring-shaped hypodensity on the images. This is our next patient, an older male who presented with hematuria, and we were suspecting a urothelial tumor. Urothelial malignancy is a disease of older men with history of smoking. We want to perform a CT urogram, where a CT is acquired without contrast, then post-contrast, and then we acquire delayed images. Most of the times the mass is arising from a wall of the urinary bladder and protruding inside, and so on the post-contrast images, there is an enhancing mass. On the non-contrast images, you may be able to see the superficial calcifications very well, which are present a lot of times. And then on the delayed images is when the mass is delineated by this excreted urine into the urinary bladder. And so that's the large mass arising from the right lateral wall of the urinary bladder growing into the lumen. Sometimes in advanced stages, we may be able to see the invasion of the urinary bladder wall and metastatic disease to the regional lymph nodes. Here is a patient with abdominal aortic aneurysm. So that's the aneurysm on the top left image. This is the patent aortic lumen, and then we have mural thrombus. The patient was treated with a endovascular graft, and after the graft placement, the excluded lumen has collapsed, and more inferiorly, we find that here is the aneurysm, and we place the stent graft inside, and then over a period of time, the excluded sac has become smaller in size. And so one of the roles of follow-up imaging in such patients is to make sure that the excluded sac is decreasing in size over time. But if it is not decreasing in size, stays the same, or increases in size, then we have to look more carefully for a cause of an endoleak, which may need further treatment. This is our next patient, and on their CT of the abdomen and pelvis with contrast, we find that there are abnormal findings in both kidneys. There is patchy hypoenhancement right here, also seen on the coronal images, consistent with acute pyelonephritis. There is some reactive free fluid as well. Here is our next patient, and they presented with pelvic pain. We performed a MRI of the pelvis with vaginal gel. That's the vaginal gel. This is high signal from urine in the urinary bladder. So this first image is the sagittal image. Then we have the axial and the coronal. Small field of view T2 weighted images. This is the endometrium, and we find foci of high signal in the myometrium suggesting adenomyosis. And we also find that there are several areas, foci of low T2 signal consistent with fibroids. So uterine leiomyomatosis and adenomyosis. The patient underwent a hysterectomy. This is our next patient. Here, we were trying to find the cause of abdominal pain in a young male, and we incidentally found absent left testicle. And so sometimes the testicle are not in the field of view in the CT of the abdomen and pelvis. And so a good idea about the presence or absence of testicle is from looking at the axial image and finding the absence of spermatic cord on one or both sides. So here on the coronal image, we find the spermatic cord leading into the right testicle. On the left side, the spermatic cord and the testicle are absent. So this was congenital absence of left testicle in this patient. On the rest of the CT of the abdomen and pelvis, there was no finding to suggest an ectopic testis. This is our next patient, a young female who presented with abdominal pain, and a large mass was found. This is a complex cystic mass. Some of the hyperdensity suggested that there may be some internal solid tissue or hemorrhage. This patient should have gotten a MRI to further evaluate where this is coming from and what is the nature of this mass. But since the situation was acute, she was taken to surgery, and the pathology, a tumor was found arising from the pancreas, which was resected, and the pathology showed SPN, or solid papillary neoplasm arising from the pancreas. It's a complex cystic lesion seen in younger females, and they're better characterized by MRI. This is our next patient. They presented with a adrenal nodule, and on in and out of phase images, we see your in phase image, we see some signal, and on the out of phase images, there is signal drop. So this nodule in the right adrenal is an adenoma, and remember, adenomas can sometimes show restricted diffusion like this one, high signal on DWI and low signal on ADC images. This is our next patient. On the T2 weighted image near the dome of the liver, we find a focus of high signal intensity. It fills up with contrast on post-contrast images, so a hemangioma. And what I want to emphasize here is the appearance of hemangioma is based on the surrounding liver signal. So on the in-phase image, we find that there's high liver signal, and so the hemangioma is seen as a low signal. And on the out-of-phase image, because there is hepatic steatosis, there is signal drop, and the background liver becomes dark, and the hemangioma becomes a brighter or shows a higher signal. This is our next patient. They had a percutaneous biliary drain, and we performed a multiphasic CT, so non-con arterial phase, portal venous phase, and delayed phase, looking for any bleeding. There is some free fluid or ascites. There is some hyperdensity there, so they have already bled, and we are looking for source of bleeding. This is contrast extravasation into this little hypodensity in the liver, and it becomes more dense with time on the delayed images. So here's a good example of hemorrhage around the biliary drain, and from somewhere through the capsule it was leaking into the intraperitoneal compartment. Thank you for watching.